Thank you so much for having me, everyone. And please let me know if you can't hear me. But my name is Anuja Jindal, and I am at Rady's as a pediatric neurologist, just like Dr. Trask said. And my specialty is neurodevelopmental disabilities. I am going to be speaking about autism spectrum disorder, which is something that I see quite often, as I'm sure you all do as well. I have no disclosures. At the end of this presentation, you should be able to understand my role in taking care of a patient with autism spectrum disorder, discuss standard of care genetic testing, and be aware of management options and available resources for children with autism spectrum disorder. So this slide is just going over the clinical diagnostic criteria that is per the DSM-5. It basically lists the check boxes that sometimes will be used when we're seeing a kid, a child that we are diagnosing with autism spectrum disorder. First of all, we are looking for persistent deficits in social communication, social interaction. We're looking for patterns of restricted, repetitive behaviors, which include sensory concerns. We're looking for symptoms that must be present in the early developmental period, and this is a little vague on what early actually means. We're also looking for symptoms that cause significant impairment in daily functioning. And these symptoms are not otherwise better explained by intellectual disability or global developmental delay. This is generally a pretty common criteria in the DSM-5 or any DSM manual prior to this, that these symptoms are usually not explained by another disorder. Delving a little bit deeper into this, in terms of persistent deficits in social communication, things that we look for are deficits in social emotional reciprocity. We're looking in deficits in not just verbal communication, but in nonverbal communication. This can sometimes separate a child with isolated expressive language delay versus a child that has actual social communication deficits. And then we're looking at difficulties with not just maintaining relationships, but understanding relationships, understanding how to interact with peers. There may be children that want to interact with peers, but they can't figure out exactly how to play with them, how to play with toys in general, or engage in some more advanced pretend play, imaginative play scenarios. Other things that we're looking for are these restricted or repetitive patterns of behavior. For the criteria to fit, at least 2 of these following 4 have to be present. So this includes some of those repetitive movements that we see. This includes either rigid thinking and need to stick to a certain type of routine, or have certain what we call kind of compulsive type behaviors. And like I alluded to before, now in the DSM-5, this also includes sensory concerns, so sensory avoidant behaviors or sensory seeking behaviors. All of this leads me to saying that at its core, autism is merely a constellation of symptoms. Each child that's diagnosed with autism has a unique set of these symptoms. You can imagine seeing the list of symptoms that could be present. Really, you don't need all of them. So every child has a different set of symptom combinations and even a different set of severity of symptoms. And this is part of the reason why autism is considered a spectrum disorder. And this is why you can have children that present very, very differently at different points in their lives. This also makes there's this phrase that's been uttered in many communities associated with autism. If you've met one child with autism, you've only met one child with autism. So my job is, we have a child with autism. Why do they have autism? First, kind of going back, in terms of autism itself, it's rather prevalent now, and that's why we are seeing this more and more in doctors' offices. We're seeing more and more in terms of dealing with this in the school setting. The prevalence is currently 1 in 54 children will be diagnosed with an autism spectrum disorder. And again, this includes children all along the spectrum. This is the same prevalence has been seen internationally and nationally. It's been seen across all types of ethnic and racial groups, all types of socioeconomic groups. It is, and it has been very steadily seen more commonly in boys than in girls. Currently, it's seen 4 times more common in boys than girls, or previously it was about 5 times more common. And overall, in the past 50 years, there's been a significant increase. So why? Why is it increasing? And this is a question that not everyone has the best answer for. The leading theories, and the ones that I believe probably make the most difference, are greater awareness and better screening. I think we also have better diagnostics now. The way we're diagnosing autism, where we're using better clinical tools, and we are more accurately diagnosing it. I think many of these children, maybe 50 years ago, would have been diagnosed with something like intellectual disability, which we used to call mental retardation back in the day, or simply an isolated language impairment. Some children may have just been called weird and not really delved more into why they had the behaviors that they had. And so I do think that has a lot to do with it. Better diagnostic, increased screening. As families are becoming more aware of this diagnosis, they're seeking medical care. Also, there's been some increase in genetic syndromes that are associated with autism, and that's a little bit of a separate talk, but I think that's part of it as well. One thing that we actually haven't seen too much of, even with the change in the DSM from DSM-4 to DSM-5, there was a change in how autism was categorized and some of the criteria used to diagnose it. Studies have found that despite that change, overall, there's been a pretty consistent prevalence between the two. And we also haven't found that environmental factors are very likely. There was actually this really, really nice paper that came out very recently in JAMA Psychiatry, and I think this is available to mostly everyone right now, so I really highly recommend it. But they were looking, it was a Swedish study, and they looked at 2 twin cohorts, so 2 twin studies that were done over a period of 20 years for one, and I believe it was 15 years of another. And they basically compared twins. They looked at the prevalence of autism in both of what they called autistic traits, and they looked at various factors. And what they found at the end of the day was that environmental factors really didn't make a difference over that period of time. And things that they looked at were education of parents, they were looking at age gap, they were looking at socioeconomic status, things like that. And they didn't find that that made much of a difference. But they did find that genetics really played a larger role in this than environmental influences. Now, this all being said, 1 in 54 children has autism. What can we do to help them? Many, many children, which means many, many hands need to be in this pot, and we need a team approach. I'm sure you will all agree on this call right now that everybody in this child's life is important to making sure that this child succeeds. So not just the people I've listed in this wheel, there are many other spokes on this wheel depending on the child, but this is just a flavor. How many people can be involved in caring for a child? And everyone has a little bit of a different role. Most of our roles overlap. But at the end of the day, because I feel that it takes a very small village to raise a child, I think each one of these people is incredibly important. So my role, what do I see myself as contributing to the care of a child with autism? I think it can be one of several things depending on the needs. I do help with diagnostic clarification. We're looking at etiology, we're looking at causation, looking at other diagnoses that can come along with the diagnosis of autism, and also looking at what we can do to help medically in terms of medications and things like that. So for diagnostic clarification, there's a range. So sometimes it may be that autism is suspected as a diagnosis, and we need to see if that is something, if we're on the right track, if that's something that that is clinically justified based on DSM-5 criteria. Sometimes it's that a child already has autism, but we have a feeling that there's maybe something else going on more than quote unquote just autism. and just to make sure that we're not missing anything, we're not overlooking some other neurodevelopmental disorder and wrongly calling this autism. Part of my evaluation, I do, of course, we always want a really, really good history and a physical exam. Part of the physical exam, from my perspective, is getting a head circumference, is getting a really good skin exam, which hopefully Dr. Boyko appreciates. The skin can tell us a lot about the brain. And then there's a series of tests that I may or may not want. This can range from laboratory work to imaging to EEG, but it can vary for each child. And then, of course, as part of an evaluation, I'm looking over anything else that's been done, any sort of psychological evaluations, psychoeducational evaluations. I want to look over their IEP, see what their teachers have to say, see what their therapists have to say. And then we have screening measures that are done in a lot of pediatricians' offices. So the MCHAT, and SCQ is something that is done in some psychologists' office, and I'll do that sometimes as well. Vanderbilt forms, things like that. In terms of looking for causation of autism, one thing that I'd like to talk a little bit more about is genetic testing, which I consider, which is actually considered by many, many societies out there as standard of care in assessment of children with autism spectrum disorder. Also, one thing that I feel like almost every child with a language impairment should get is an audiology evaluation. And this is more than just a basic hearing screen, but referral to an audiologist for a little bit more ear-specific, frequency-specific testing, only because this is something that is very treatable if we find a cause for a hearing difficulty. And then a case-by-case basis, looking at EEG, looking at neuroimaging, looking at metabolic testing. Sometimes we're looking at EEG more often, of course, if there's concern for seizures. But also I'm getting an EEG to look at causes of some rare disorders. There's this entity of disorders that are associated with language regression and significant language impairment. And they can have a very specific signature finding on the EEG that can be very, very helpful. And this has a potential type of treatment. And so the fact that intervention could change means that this may be something that I want to do, depending on the child. Now, neuroimaging most often includes an MRI of the brain, but not always. An MRI of the brain is generally normal in children with autism. But if there's a concern for something else, some sort of movement disorder, a really large head, a really small head, really low muscle tone, then that would give me another push for moving in the direction for neuroimaging. And then metabolic testing. So these are different types of labs, your normal electrolyte panel, liver function panel, but we're also looking at thyroid and muscle enzymes and a lot of different other kind of enzyme and amino acid type testing, looking at other reasons for delays or regression in a child with autism. This is what I was talking about in terms of a specific EEG signature for a child with a language regression. It's associated with, there's this one specific type of syndrome called Landau-Kleffner syndrome. You can see that on the left-hand side, this is an awake EEG of a child's brain waves, and this is very normal, and there's a lot of variability in it. But on the right, when the child is asleep, you see a lot of these spiky type things, and it's very, very regular. And the classic finding is during sleep, you'll have a lot of these discharges. And the thought is, depending on the location of these discharges, it can interfere with development of language possibly, or something else, depending on where in the brain this is occurring. And so our goal would be to temper that down a little bit with medication and help, hopefully, a child progress in their development. The role of genetics in autism. So a lot of studies have shown, and every geneticist will tell you, that autism is what they call multifactorial inherited disorder, where there is thought that there is an inheritance pattern to this, but it can be influenced by lots of different things. There's something called epigenetics, so how a gene functions, even if you inherit the gene, can be determined by lots of different factors as well. But we do know that there is some sort of heritability. The recurrence risk increases with each subsequent sibling diagnosed with autism. And there's a really, really high concordance rate in monozygotic twins, as opposed to dizygotic twins, which their rate of recurrence is similar to another sibling. And for some reason, it's more common in males than females. And we feel like genetics plays a role in this a bit, especially if there's inheritance of disorders that really affect the X chromosome. And since males have only one X chromosome, they could be affected more often than a female who may have a second protective X chromosome. So what's the purpose of genetic testing? We get genetic testing sometimes to help us determine if there is a cause to be found, but what else can it help us with? My main selling point in talking with families is that sometimes if we can identify a genetic disorder, we can see if that genetic disorder is associated with any other medical issues in other patients. And that helps us determine, do we need to be doing any other appropriate medical surveillance? I've had several patients that have been diagnosed with different types of genetic disorders. One that stands out to me was a child that was diagnosed, I think it was a 15q duplication. And this specific type of chromosomal disorder was associated with aortic dissection or widening of the aorta and putting him at risk for rupture of the aorta and then leading to imminent death if that were the case. But because we were able to find this chromosomal abnormality at a young age, I sent him to cardiology. They were able to get the right imaging to look at the aorta. It was a little widened, but not too much. But now he's getting very, very regular follow-up to ensure that they can intervene if and when they need to before it gets to a point that is really, really fatal for the child. So that's a small example. That's not a common example, but that is an example of something that could be helped by genetic testing. Our hope is that genetic testing can eventually help with targeted treatment, such as gene therapies and clinical trial eligibility. We're not there yet for most syndromes associated with autism, but the hope is that someday we will be. Sometimes this doesn't help end the diagnostic odyssey. Sometimes parents just want to know everything. And this can sometimes be helpful in giving them some more answers one way or the other. I always tell parents, even a negative test is very, very helpful at the end of the day. This may prevent more invasive testing. There are certain syndromes that they're really, really well described and well documented, and that can help us, it can tell us that, okay, this type of symptom is seen quite commonly in a child with this genetic syndrome. So maybe we don't have to do more testing, such as macrocephaly. There's certain genetic disorders that are really associated very commonly with a large head size. And say I got that result back, this may prevent me from putting the child through an MRI where he needs general anesthesia and has to go through all that whole process. Sometimes this can help provide more specific genetic counseling. So if there's a certain disorder that they need to look further into in terms of other family members, this can be helpful. And it may also help acquire services and empower families. So the main societies that actually deal with patients with autism all agree about genetic testing being the standard of care. The American Academy of Neurology and Child Neurology Society put out a practice parameter in 2000, and they're redoing it now, thank goodness, since it's been 20 years. The American College of Medical Genetics also agrees that a CMA as a chromosomal microarray in Fragile X testing is standard of care in first line. And what's really, really nice is the American Academy of Pediatrics put out their position statement just this year. And if you haven't read this paper that they put out, it's in my references, which I'll show you at the end. I think this is a really lovely paper. I think it's a very well-written paper about autism spectrum disorders in general, the role of a pediatrician, and what testing is recommended. And I do encourage all of you to read it. As I said before, standard of care is a chromosomal microarray and a Fragile X PCR. A microarray is just looking at little small duplications and deletions and known, and basically a set of genes. Fragile X PCR is looking specifically for something called a Fragile X disorder. The way this disorder presents itself, you cannot detect it on a microarray. And so that's why we test for it separately. But it is one of the most common known genetic causes of autism. So we do like to screen for that, especially in boys, because again, because it affects the X chromosome, they are more likely to be affected by it than a female that has that second protective X chromosome. What's becoming more and more common is whole exome sequencing or whole genome sequencing, which is something that I tend to advocate more for in children where I strongly suspect an underlying genetic condition, but their microarray and their Fragile X was unremarkable and unrevealing. Then I want to take that extra step and do this this is more of an extensive genetic test. The American Medical College of Genetics is starting to, I believe, advocate for this as part of first-line testing, and the AAP did recognize that this is being done more and more often and may become standard of care. There are other genetic tests that we'll sometimes do if we're concerned about some specific disorders, which are listed here, and I won't go into right now. So we talked about causes, evaluation for possible causes, but other things that sometimes they'll screen for, other comorbidities that are associated with autism that we'll sometimes see in children with autism spectrum disorder. And this can include language disorders, motor disorders, intellectual disability, neuropsychiatric disorders, and epilepsy. So very quickly, there's a really high concordance rate between autism and epilepsy. Up to 30% of children with autism will have a seizure at some point, and the peaks of onset can differ, and the types of seizure can differ. But there is an association, and there's a clear association that children with epilepsy are more at risk for cognitive impairment. A higher rate have abnormal EEGs. So if up to 90%, 80 to 90% of children with autism have an abnormal EEG, should every child with autism get an EEG? And that's a common question I get asked. Honestly, I say no, but this is open for debate. I think an EEG is helpful in the right clinical setting. Epilepsy, at the end of the day, is a clinical diagnosis. So that means that based on a history and based on your index of suspicion and just the symptomatology, you decide if a child meets a diagnosis of epilepsy. An EEG is merely supportive information. Someone can have epilepsy and have a completely normal EEG because at that point in time, they were getting the EEG, the brain waves were normal. And someone with an abnormal EEG can never have a seizure in their whole life. So if you have a clinical concern for seizure, I would recommend an EEG, or if we have other signs that maybe there's something else going on, such as language regression, declining school performance, then I may advocate for an EEG as well. And the second question is, should every child with an abnormal EEG be treated? Again, I say no, but this is open for debate. Many of us will likely have an abnormal EEG as well, but we may never have a clinical seizure. So should we be on a daily medication to prevent that from happening? I don't know if the benefits outweigh the risks. Now, in a child with autism, that's an increased risk for having seizures over the course of their life. That's where this becomes a little bit more tricky. And this is when it involves a sit-down long discussion with parents about risks and benefits of medication, whether or not it's worth it, how severe are the abnormalities that we're seeing on the EEG, because there are different degrees of severity, and which would again either push me towards medication or not. And again, clinically, how are they doing? Are they thriving? Are they making a lot of progress developmentally? Have they never had a seizure in their life? In that case, I probably wouldn't want to treat just the EEG, but again, open for debate. We see a lot of motor impairments in children diagnosed with autism. And I'm going to skip through this a little bit because I know we're running out of time. And what I really did want to talk about just a little bit more is ASD and COVID-19. And so you can see that there's lots of other things that children with autism can suffer from. And so depending on their symptomatology, we'll manage things in a different way. Things that I'll use medications for are different types of behaviors, sleep difficulties, and of course, seizures. And just keep in mind that there's no medication yet for the core symptoms of autism. So for those social communication difficulties, there is no actual medication for that. And the most important thing for management at this point in time that we know are supportive services and ancillary services. So everything therapists are doing, everything that teachers are doing, that is the most important thing for helping these children thrive. So management during COVID-19, what have I found in these past 6 months? As you can imagine, it's been very challenging. I think it's been challenging for families, it's been challenging for schools, this has been challenging for obviously the children, themselves. The one positive aspect I found from this is the advent of telemedicine and the increase of telemedicine. I think that a lot of my families love this, and I actually love being able to see children in their own home setting. It's really, really eye-opening, and I think it just gives me a much clearer picture of everything they're going through and everything they're seeing, rather than a child sitting in my office and getting antsy just sitting in this dark little white room. But the challenges have been really, really pretty awful, actually. So you have children that have either no services, all their services are on hold, or limited therapies and services, or only services through telemedicine. You have lack of structure, so they're not in their regular school day, they're not getting their regular therapies, parents are home, siblings are home, it's chaotic and routine is off. And then you have a lot of caregiver stress and school stress because of everything else that's going on financially, socially, emotionally. Put all this together, it's the perfect storm. You have worsened, challenging behaviors, you have kind of stagnated development and school performance. And, I can just imagine how difficult it's been. It's difficult for me as a mom of 3 young children that don't really have significant behavioral challenges. So I can only imagine how it is for these families. And I don't have great answers, and I don't mean to disappoint you with that. But truthfully speaking, I don't have great answers. But over the past 6 months, some things that I've learned. So televisits. What do I think about them? You know what? At the end of the day, I think something may be better than nothing, but not always. It depends on each family. There are some families where televisits they're really creating much more stress for these families, because a parent is serving as the therapist and the parent, and the child is just not as compliant by listening to the parent. And so this is a really case-by-case basis. A lot of parents ask me, should we be continuing? And part of me wants to say, if it's causing more stress than not, then maybe put it on hold. The only caveat with this is, as you can imagine, sometimes when therapies are put on hold, it's really hard to access them again. So if that's going to be the case, sometimes you just need to hold on to it to ensure that you can go back to your regular therapy and therapeutic care once all this has died down or over, which of course we don't know when that's going to be. School. So in an ideal setting, I'd want every kid to go back to their normal school day, their normal therapies, their normal structure. But what should these children do? And again, this is a really, really individualized discussion. Some parents say that, I understand the risks, but I really, really need them back. And for me, those benefits outweigh any risk of exposure. And other parents say that, I can't, my child gets sick really easily. I know they're not going to keep a mask on. I know it's going to be very difficult for them to see teachers with masks, and it may end up creating more stress at the end of the day. So maybe, I don't have that school structure, but I'll accept a few more behaviors for that. And so again, it's really an individualized decision. At the end of the day, all I want to do is support the parent and make sure whatever decision they make, we can make the best out of that situation. The one thing I always tell parents, just make sure your kids can get out and run around a little bit. Physical activity, absolutely, I feel like is helpful for, decreasing that restlessness, helping with sleep, keeping a little bit of routine on hold. I always get concerned about mental health in patients and caregivers. I do talk a little bit about, using the services they have. So if it's respite care, if it's IHSS services, trying to maximize those as much as we can. And the final point I'll make, and I know I'm running over time, I apologize, medications. So a lot of families, medication is a huge decision. I acknowledge it's a huge decision whether to put your child on medications. And there are families that have been resistant to this for a long time for various reasons. And then finally, COVID hits, things are getting a little out of control, and families are looking for something to help with some of the behavior. So they come to me and they ask to start medication. I don't want parents to think that it's something that is written in stone if we start something. I think it is okay to start something depending on what your unique situation that you're in, and it's okay to change that once the situation has changed. And I don't want them to feel like they failed or that they've given up on their child because this is the road that they've gone down. And so again, at the end of the day, it's just offering a lot of support. Here are some resources that have been really, really helpful during COVID online. And so you'll have access to these. And again, keeping in mind the multidisciplinary care model, that we're all in this together and we really need to work together to help these children. And that's it. Thank you very much.